Welcome to the Medicare Advantage Denials webinar. This webinar uses data to explain what we're seeing with claims denials. When I say we are talking about traditional fee-for-service Medicare. We do not have access to each individual Medicare Advantage plan or Part C plan denials. This means we cannot cover specific denials or specific questions related to that. This is about Medicare fee-for-service and the denials that we are seeing. I'm Tom Ryan with Provider Outreach and Education. I'll be your presenter today. Today I'm joined by Karen from my team, and she's going to help with that chat area, looking at questions, giving you additional resources, all of that types of things. I want to remind you that at the end of this presentation, there is a disclaimer. The disclaimer is something you'll want to look at or be aware of. Basic gist, hey, this information can change based on what's going on with Medicare. We all know that Medicare is not a static program. And there are changes going on. So keep current on that. Objective. Again, my goal today is to look at Medicare fee-for-service, J5 and J8, Jurisdiction 5, Iowa, Kansas, Missouri, Nebraska, plus our national contract, and Jurisdiction 8, Indiana and Michigan, and what's going on with MA denials and why it's so important that you have a basic understanding. Now, goal is to reduce that denial base. However, in order to do that, you have to understand what MA is to start with. Then you have to look at the steps to avoid the MA denials. And then I'm going to show you some tools to help with eligibility, because if you're not sure if they're on an MA plan, how can you avoid billing us for a denial, right? So we want to make sure we get through all these different agenda items. With that, there were a lot of questions, pre-submitted questions, and I will try to work through all of them. Then I'll move into chat questions should we have time. But remember, if you place a question in chat and I don't get to it, I will answer those via email. All right, let's get started with a little bit about the basics. Someone did ask for the difference in the MA Medicare Advantage plans and Medicare. So in order to do that, we really have to start back and start at the basics and talk about what an MA plan is, what is traditional fee-for-service Medicare, why are they different, things like that. So I do want to get started with just some plan basics. First, a Medicare Advantage plan goes by many different names. Some will say Medicare PPO, Medicare HMO, some will say Part C. Those are just a few samples. They're all related to what is known as Medicare Part C, and they're all replacing traditional Medicare. In other words, the patient wants more options with Medicare other than just Part A and B, which is what's known as traditional fee-for-service Medicare. With that, they can choose, the patient can choose, and we'll talk more about that on the next slide, an Advantage plan. Okay. There is some basic rules. They must offer the benefit that traditional fee-for-service does. Did you guys catch that? They must offer the benefit. Here's what they don't have to be defined as. Does the benefit have to be offered the same way as traditional fee-for-service Medicare? Nope. Does the benefit have to pay the same amount? Nope. Do they have to follow the same Medicare guidelines? Coverage guidelines, yes. So they must cover something that would be within a national coverage determination or a local coverage determination for that state. However, they can do it in a different way. And I'll talk more about that in just a second. The next thing to be aware of is, do they have to pay the same amount? And the answer is no. So while traditional Medicare may allow $90 on a service, the Medicare Advantage plan may say, hey, we're only going to allow $75. Or they may say, this is part of another service. We're going to bundle this into a payment, but we're going to give you $150. And I'm going to use a little bit of an example here. Many of you have probably heard of the IPPE for traditional fee-for-service Medicare. This is the initial preventive physical exam, and then also it has an annual wellness visit, so the first visit and then each one thereafter. Some MA plans or some Medicare Advantage Part C plans include this as part of an annual physical exam. We don't cover that exam. That's considered routine services. It's not necessary. But some of the MA plans do based on the patient. And because it's included there, they say, hey, we're going to give you $150 for this entire service, which includes the IPPE and the AWV, depending. So you can see, yes, they're still covering it. It's just not the same way. With that said, they can also have different patient responsibilities. So because they're incorporating this into a annual exam, right, an annual physical, whatever you want to say with that one, they can say, hey, the patient owes you $20 per physical, where Medicare would say, hey, wait, these are part of our preventive care package, traditional fee for service, so they don't owe you anything. So it's a very different set of information. Okay. And one of the things that you'll see as my last difference is way the plan offers a benefit. Now, I explained that for one example, but what else does that mean? A plan can require a prior authorization to see a certain provider. That's part of what the plan is doing. So it's not that they don't cover it, they would cover it, but did you follow the plan rules? And that's asked to the patient because the patient has elected this plan. So could something that was paid at a certain level for traditional fee for service Medicare be paid at a different level with a different copayment amount, all of that, with a different deductible applied under an MA plan? Yes. As a matter of fact, each Medicare Advantage plan could process those differently and apply different dollar amounts, different allowed amounts, all of that. This is Medicare coverage. This is not primary secondary payer situation with traditional fee for service Medicare. Either they pay it or we pay it. That's all you got. And that was one of the questions that was asked is, do I have to submit these as secondary payers? And the answer is no. Now, there is an exception for some inpatient care where you would submit it to track a benefit period and things like that, but that's not really about the MA. And we do know that those claims are considered covered claims for Medicare. However, the MA plan is paying while you're submitting to traditional fee for service Medicare for tracking purposes. A little bit of a different situation. I wanted to throw that in because there was a question is, do you guys still need to do that from a facility perspective? And the answer is yes. That doesn't change. It's a no pay claim. Okay. Um, so joining, how does this happen? First, for a patient, they have to choose the plans. Now, they do have to have Part A and B unless the plan is older and specifies that it's a Part B only plan. The reason that I say is older is because the Part B plans, the ones that just cover Part B services, CMS does not allow new plans. It has to be one that was already in existence and is already in place. So it has to be an older type plan. It doesn't mean someone can't join it today. It just means that it would not be in effect for that service. When we say Part A and B, Medicare will refer to this as traditional Medicare. Part A is the hospital or the inpatient insurance, and Part B is the outpatient professional and supplier insurance. So hopefully that all makes sense to you. They do have to live within a plan's service area unless the plan is a national plan, in which case that is the entire United States. That is the service area. These plans can be offered only in certain geographical areas, which do include the U.S. territories. And you do have to be a U.S. citizen and lawfully present in the United States or its territories in order to be eligible. So that's one thing that the Social Security Department tracks. It doesn't have anything to do with Medicare itself. It's actually tracked by the Social Security Department, who allows the plan to enroll them. Now, someone asked very specifically, how do I as a provider join a plan? And that is an interesting question in that each plan can require the provider to enroll separately, depending on what that plan has for needs and what additional benefits they offer. So we'll talk more about that as we get a little bit further into these slides. One thing that is definitely, one thing that is definitely something you want to be aware of. Each individual MA plan offers a unique card. This does not mean that the traditional fee-for-service red, white, and blue card is not active. It is active. Remember, they have to have Medicare A and B. The difference is who's paying for it, whether it is traditional fee-for-service or whether it is the patient's MA plan. This is one of the biggest tips. Ask for all cards. Or if they present you with a card, look at some of the different verbiage on there. Okay. So we don't know, for instance, that it's an MA plan right away, neither do you. When you ask for the card and you look at Premera, Blue Cross Blue Shield, which is the lower example in the right corner, on the bottom it'll say Medicare Advantage HMO. That's very key information. That tells you to bill them versus bill traditional fee-for-service. It also tells you this is not a supplemental plan. So sometimes it'll be a supplemental plan and it'll also state that on the card. So you really have to look at the cards. This is not the same as traditional fee-for-service Medicare when it's Part A and B versus Railroad Medicare. Railroad Medicare is eligible under the Railroad Retirement Board. Traditional Part A and B is the Social Security Administration. Those are the left two cards on your screen right now. And you do want to notice the bottom card has the word Railroad Retirement Board in the bottom red banner. Okay, so you want to make sure that you're doing that. Common types. Now, this was something that I was asked about because it's what types of plans are there, or what can you be aware of? So I want to make it very clear. These are the common types. These are the ones that someone could create a new Medicare Advantage plan today and then go into, and then they have to follow the rules of that plan. So the first one is a health maintenance organization. This works very similar to any other HMO that you may know of, right? You got to have prior authorizations. You can see your primary care, but once you leave that, you do still need to use the network of providers. That needs to be prior authorized. Just because it's not prior authorized does not mean that traditional fee-for-service Medicare will kick in. It can mean the opposite. Now, usually, or will mean the opposite. We can't kick in and we won't pay for that. Okay? Usually, a person is required to live in a certain service area, but the HMO does cover emergency care or emergency services. Now, this plan will follow the base rules. In other words, yes or no, this is covered. It does not necessarily offer additional benefits, but it can. So let's go back to that basic, comprehensive, basic physical every year. Yeah, they could cover a physical every year. It's part of the health maintenance organization. Does it have to? No. That's an additional benefit that may be included, but doesn't necessarily mean it is included. On the other hand, they have to give the equivalent of an IPPE and an AWV with the same base benefit. So that's where things like the annual physicals or those basic coverage, comprehensive exams, whatever you want to call them, that's where those fall in, okay? There's also the preferred provider organization. And this one is where you get the discounts for using a certain provider that's contracted, but you can see anyone you want. So you may have a certain hospital or a certain doctor that's within their network. So therefore, they pay less. Maybe they only pay 15%, where when they use someone outside the network, they pay 25%. Again, that's all set up by the plan. It's like any other preferred provider organization or PPO. Now then there's private fee-for-service plans. These ones are becoming less and less common. I don't want to make it sound like they're not possible. They're just becoming less and less common because on that fee-for-service plan, they work very similar as original Medicare. And so they also, but then sometimes add in what we would call Medigap coverage or supplemental insurance coverage. That's the additional benefit. So you get one with both. That's why that sometimes works that way. The plan itself determines how much they'll pay a doctor. They determine other health care they're going to coverage, hospital coverage, all of that type of thing all comes from this private plan. Okay, they do pay for fee-for-service basis without placing the provider at a financial risk. In other words, most of these do not require prior authorization. They don't have a, you get more money if you go to this provider versus that provider. It's just a private fee-for-service plan. The payment rates, though, they do vary. So they can vary by specialty, they can vary by location, they can increase utilization or prevent screening zones, all of those different types of things. They do not restrict a member's choice. And that's one of the key things that some members really like, is that it's not a restricted choice, but they could also have a restricted service area, and so you have to live within. So even though it's a fee-for-service plan, right, it still could have that restriction. The next one is very unique. It's very common in some areas, and other areas have never heard of this before. So this one, if you have one, you know what it is, and if it's not in your area, you've never heard of it before. This is what's referred to as a special needs plan. They offer targeted care for a patient with a chronic or disabling condition. This care is specially designed to help them. Now, because they have this chronic or this special need, they may also be on Medicaid, and a special need plan can combine the Medicaid and the Medicare coverage into one payment. So the really big thing to remember with this one is it's eligibility driven based on the patient's medical condition. It will always cover Medicare Part A and B, and you always have to be living in that service area. Other things, though, it could incorporate the Medicaid payment, not uncommon. It could offer additional benefits, so a better therapy benefit for someone who has a degenerative disease. Therefore, there is one. When my grandfather was diagnosed with Parkinson's, one of the plans that approached us was a Parkinson's plan in that state, and specifically asked, hey, this might be something good for him. When our family looked at it, it was determined that that was actually a better need, but you had to have Parkinson's to be in it. So he qualified based on that need, and it gave him some additional benefits which were helpful with maintaining his lifestyle. The last one that is very common is the medical savings account, and this is just like any other savings account. It's money put in, they're allowed to use it however they want. Medicare gives the plan an amount of money each year, and that's what pays for that health care. So those are your common types, the ones that could still enroll today. But there are some other ones, and I like to call these grandfathered in, if you will. These are the ones that you can't make a new one today, but if they're in your service area, they still could be in existence. So the Religious Fraternity Society plans, it's a not-for-profit organization that provides insurance and other benefits to its members, but they have to share a common religious. The religious bond is very important. It is what makes this plan that portion of it. It is done through a church or an organization such as a church, so some religious organization, they sponsor it, they have the plan in place. Okay. Again, not as often, I guess, even utilized anymore. You're seeing less and less of these. There's an older plan, and it's called a Medicare Part B only plan, and this is one where the patient does not have Part A, but they can still take this plan. Now, why would someone not have Part A? It's because they didn't work enough quarters in their lifetime, or their spouses did not work enough quarters in their lifetime to make it free. And if you work if you work 1 quarter to 39 quarters, there's a fee for Medicare Part A, and it can be very expensive. So as an option, you'll get Part B, and you can pay for that. It's much cheaper. And so this was a plan that worked with that. The next option is Medicare cost plans, and these are both inside and outside the plans network, but costs are covered by the MA plan for in-network providers only, and original Medicare for out-of-network providers. So this one got a little confusing for many people and has caused a lot of issues. We don't have many of these left within our service areas, but there are a couple of them. And so in this case, you would need to bill, if you're networked with this plan, the MA plan. If you're not, then you would bill original Medicare. So that one gets just a little confusing. There are also healthcare prepayment plans. Typically, these are sponsored by a union or employer. They're providing coverage for Medicare Part B on a prepayment basis. So an organization is paid for these services. This could be physician services, lab services, anything covered under Part B. And then for Part A care, which would be your inpatient style care, that all goes to Medicare traditional fee for service. So there was a lot of older plans, and again, not as common. Okay. All right. So that's kind of walking through the plans and some of the unique things about them, but let's keep going here. When we look at traditional fee-for-service Medicare, we look at data and we say, okay, what's going on with the data? Again, J5 and J8 data, we mix it together and then we look at it. We also look by processing system. So you will hear that sometimes within my realm. You'll hear MCS, or the multi-carrier system, which processes 1,500 and 837P electronic transactions. And you'll also hear FIS, Physical Intermediary Standard System. This processes UB04 and 837I electronic transactions. So sometimes it does vary a little bit within the data, and I do want to point that out. So what I did is I went through and I looked at data. And when I looked from June 1st to August 31st. So there's a lot of data in there. And what I discovered was that it's one of the top denials. And that top denial means that they're on an MA plan, but it was still billed traditional fee for service. So that's what we're really going to talk about. And when we looked at it, we said, hold on, there's 273,000 lines denied for this. It's a 5% increase from the previous 3 months. And then we went on and I said, okay, let's do a little bit more data. And I went all the way back, and it was more like a year back. And there was 455,419 lines denied, which did lead to a decrease, obviously, from the current data that I'm doing, but still a significant number. And this is per quarter. This is not a yearly basis. And that's why it's a 3-month section or a 3-month time frame. So the data looked at it and said, maybe we do need to do a bit more. And maybe we need to move forward and talk a little bit about it. And that's where we came from. Okay. So we know that within this is affecting approximately 1,868 providers. That's a lot of providers, but it affects 11,000, a little over 11,000 patients. Again, 11,000 patients affected by this denial because it wasn't done correctly in terms of looking it up and making sure to get billed. It affects a total of $9 million for 1 quarter. So that's a lot of money, and that's what led us to deciding this, okay? I was, again, very rightfully so, very specifically asked about this information. And the information that was asked about is, why is an MA plan not responsible for hospice care? And so what we did was looked a little bit into it and got some information. First, the MA plan is not responsible for hospice care because the law states that it pays only medically necessary care. Hospice care, by base definition, does not fit into this. What's happening with traditional fee-for-service Medicare is that people are billing this to us, but they're not indicating that it's hospice care related with the appropriate modifier, GDGW, or the condition code, which I forgot. I'm sorry, I can't remember. I'm going to see if Karen will look that up for me. But what's happening is, because of that, then we have to do something and we deny those claims. They're automatically denied. So you need to bill traditional Medicare. That's great. Here's one of the key things. You have to wait for the hospice election to come in. If we have no election for hospice, we don't even know that the patient's on hospice yet. And you can check our website and find that information. I'll show you that in a little while. And then you also have to make sure it's reasonable and necessary, right? It's reasonable and necessary. So hospice care doesn't cover everything. It's not an everything benefit. Oh, and I also see that someone said it was condition code 07. Thank you. So on a UB04 or 837I, it's condition code 07 if the entire claim is affected. Otherwise, modifiers GV and GW. So we went in a little bit. We pulled some federal regulation areas for you guys to take a look at if you're interested. Hopefully they will help you kind of determine what you need. So very, very important for that. Another area that I think is important is to look at the day-to-day operating instructions. Now, the hospice information is within the day-to-day operating instructions as well. It is not in traditional fee-for-service Medicare day-to-day operating instructions. Instead, it's in the Medicare Managed Care Manual operating instructions. So I think someone saw this slide and they put a question on there like, what is this or why is this different? And let me just show you real quick. On the CMS website, there are what's called regulations and rules. So if we go to Medicare, we go to regulations and guidance. I'm sorry, it's and guidance, not rules. And once you open that, you're going to go to the word manuals. This is what we as a contractor must follow, but you as a provider also must follow it. It's the manual systems. Once you're inside the manuals, go to the internet only manuals. And then if you scroll down, you can see a lot of different manuals. Now, a lot of people stop at this and they don't realize that if they go on to the next page, they're going to get more manuals. Now, here's where we have a couple of things. 116-16 is the Medicare Managed Care Manual, and 100-11 is the PACE, the Program of All-Inclusive Care Manual. A lot of people incorporate PACE into the Medicare Advantage area, which is fine, but please remember that under the law, it is its own separate section. That's why it has its own separate manual. Once you go into the Medicare Managed Care Manuals, this will give you what every plan has to follow. So while it's not what we do with it, because we don't follow this, it's what the plans will do with this, okay? So you want to make sure you're following through all of these different pieces of information. I don't know exactly what you'd want to look at. That would be up to you guys, but there's just a variety of factors in there. And you can see there's just quite a few different manuals and subchapters and things like that. We do on occasion have to reference them, but not very often because our jobs is done in a different set of manuals, and that's where you'll be out here looking at all of this. The benefit policy manual is applicable to both Medicare Advantage and traditional fee-for-service, or Part A and B. This is your basic benefits package, and they have to cover it. So the Medicare Benefit Policy Manual will give you both. The national coverage determination, they do have to follow national coverage determinations in terms of coverage criteria, not necessarily in how they process it. A variety of these other ones may not be applicable at all, as they're for traditional fee-for-service Medicare. Another very important item on the CMS website is on the slides, and it's on your next slide. This is the CMS plan directory. I had a lot of questions come in about, I don't agree with how they're processing claims for Medicare Advantage. I don't agree with why they're saying this is a denial. How do we fight the Medicare denials? They're not using certain modifiers. They're not following the Medicare rules, all of that. So I may from time to time refer you back to the MA plan directory, the Medicare Advantage plan directory. Each Medicare Advantage plan is controlled by a regional office. They hold a contract with that regional office. Very similar to the Medicare A, B administrative contractors, which is what we are. We're your Medicare administrative contractor, or MAC, and we process Part A and B claims. And we are controlled based on a geographical area, certain regional office. Well, that's the same concept for the plans. So what you have to do is first know the plan. A lot of times you'll see this contract number, and some people find this super helpful. I'm actually going to open this up in a little bit, but I just want to point out a couple of fields. First, there's a legal name and a marketing name. Many people know the marketing name, but they are not familiar with the legal name. So every once in a while, our system will have a legal name in it, and you'll be like, I don't even know what that is, but it'll give you a plan contract number as well. Sometimes you have to come out and be like, that is whatever it happens to be, right? So that you can get to the right plan. So this MA plan, again, who's responsible? CMS region responsible. So let's take just a second. Oh, before I leave this slide, sorry, I should have done this too. If you don't want to have to navigate to this, use this link right here. And you can just simply click it, select it, and it will open directly to the MA plan. Unlike the other way to do it is to come back to the main page and go up to the top. Now, a lot of people say, oh, I should go to here to Medicare, but that's not where the information is. It's in the data and research area. Okay. Scroll down and you'll see a bunch of different stuff you want. So what you want to do is go to statistics and trends, which is up here in the top part. Statistics, trends, and reports. Medicare Advantage Part D. Selection, and scroll down a little bit. There it is, way down here in the bottom. You can see the MA plan directory. Sorry, it just took me a second to get there. And here you can download the directory. It will tell you the most current directory. So this one was updated in September 2025. When I select this, it asks me if I want to open it and unzip it. And I did this earlier just to save time. And then I can select either one of the sheets. I'll use the Excel sheet, and you can see it's exactly what I was just showing you. Now here you can search, whatever you want to search, whether it's the contract, the organization name, all of those. Then you're going to look towards this CMS regional office. You're going to find the regional office, and you're going to go back to the website. Going to go About CMS right up here on the top. And inside the About CMS, scroll down, and you're going to see Contact Us. This will then open the database. If you click Contact Us and then scroll down, either way, I'm just trying to get you to open either the contact database or the contact CMS. Either one is fine. By doing that, you're able to then look up and find out all the different regional offices that you need, CMS regional office, and you can select the regional office that you want. Okay. Again, just some basic information for you. Hopefully that helps you. Lots of information on the regional offices and how to find that, okay? If you are having an issue and you feel like your Medicare Advantage plan is not covering items properly, so you've contacted them, you've asked them questions, they're not covering the same thing as traditional fee-for-service Medicare, please don't contact our customer service department. Unfortunately, we can't help you. Why can't we help you? We can't tell you which plan has what built into what system and how they follow through. We can't do any of that. It's not something we have access to. On the other hand, these regional offices may be able to step in and help you determine whether or not, one, it's covered, two, is it covered as a unique benefit, or is it covered in a different way that would incorporate it into another benefit? So we really want to make sure that that information is incorporated. All right, so from there, the next big question is, how do I know if they're eligible for an MA plan? Where do I go with this? Basically, we do have a variety of different things to look at, but the basic thing starts with stop and look. Why is this important? Because to simply bill traditional fee-for-service Medicare and then let us make the determination whether it's to deny it, whether it is to do an automated response. Automated response, by the way, creates an overpayment. It's when you bill us, it looks like it's all good, we make a payment, then the MA plan comes in and enters the system, and the system, the common working file, which is the communication hub, issues us an order to take back the money based on the claims that were paid. So it's really your job to check and do all of that before we have to determine any of it. So I just wanted to make everyone aware of that it is considered sometimes fraud, sometimes abuse, most of the time abuse, simply because you didn't know. So, please be aware of what you're doing there, but it's your responsibility to determine who to bill before you bill. So how do we receive the information? How does the Medicare fee-for-service process receive this information? The patient does have to do an election with each individual MA plan. That MA plan then has their own system. The MA plan enters information into their system, giving it an effective date. That system, it's an MA eligibility system, transmits information to the Social Security information. It is not the same as their Medicare Advantage processing systems. They can be two different things. Once it transfers or transmits it to the Social Security information, the Social Security actually transfers that information to what's called a Common Working File, or CWF, and that's that communication hub. Once it's in the communication hub, it can stop all traditional fee-for-service claims from processing. No, we can't do that. Now, it will stop them from adjudicating, saying, go back to the MA plan that the patient has. And that's where you sometimes have to be like, well, what do I do next? Well, next is you need to figure out what's in the system and is it accurate in order to move forward. So that's where we do have some kind of tips and stuff to work with a little bit, okay? So first tip is very simple. Please ask the patient, can I see all your Medicare cards? Can I see all your insurance cards? Now, I know that's a very weird thing to say, but because some patients get confused over whether it's Medicare, Medicare Advantage, and they think they're different things. So you say, can I see your Medicare card? They're going to hand you the red, white, and blue card, but they're not going to hand you all insurance cards, which could be the Medicare Advantage card. Also, it could be a supplemental insurance card. Okay. Another one to ask is, have you recently changed your insurance? This may indicate that they've elected to leave or add an MA plan. This is most elections do occur at the end of the year for the start of the next year. However, there are a variety of special election periods that can affect this, and so you want to make sure you're asking that. Once elected into an MA plan, they stay in the MA plan until the following year. The one exception to that, and sometimes happens, is people with Medicaid are given certain election periods where they don't have to stay the entire year. That's not on us to determine. We know it exists. We just don't know a whole lot about it other than what I just explained. That's on the Social Security Administration to determine that. Um, if they do have a plan, whether it is on file with this, us through the common working file yet or not, you do need to work with that plan. Sometimes they'll say, no, that plan actually ended for that data service, and you can go in and check the working file. We're going to talk about that in just a moment. Check the common working file and say, but Medicare, traditional Medicare still shows you as an active plan, and because of that, they can't process the claims. It's now that plan's job to figure out what's going on. Is there a communication hub breakdown between their system and Social Security? Do they need to resubmit and try that? I don't know. We don't have access to any of that information. We just know it's there. Please remember this is especially important at the beginning of the year because that's when most Advantage plans will start. So I want to make sure you're really looking at that and checking eligibility and taking advantage of that at the beginning of the year. One of the questions that we were asked is how to find an MA plan and which one the patient is eligible for. Well, we've already talked a little bit about who controls them, but how can you tell if they have an individual Medicare Advantage plan? I will always recommend using one of the secure sections. So there's a HIPAA eligibility transaction, or HETS, information available on the CMS website. That transaction is called 270-271. That's the number for it, so don't get hung up on that. Our system offers that to you for free. No vendors, no nothing. Our system does that. How do we do that? We use our website. So let me take a minute and just jump out here again. And our website is wpsgha.com. Now, what we do require you to do is to create a unique username and password right here. And if you don't have one, then you can register for it. Okay. Karen actually teaches webinars on this and building things in it and moving around and navigating. And I'm not going to get into all of that because I don't teach those webinars. But what's great about this is that we do offer a portal user manual right here. If I open the portal user manual, go ahead and select your jurisdiction and the fact that we use CPT codes on our website. I can read all kinds of different things. It'll teach me how to register. What I'm going to focus on, though, is scrolling down and looking under patient in the eligibility transactions. In the eligibility transaction, it explains a lot about, what you're selecting, all of that. So you'll get through, you'll enter your information. It's going to bring up two different pieces. One is eligibility. This will have a variety of tabs, and one of them is MA. The other one is supplemental insurance, and that's insurance that pays after Medicare. We are not going to look at this. We want to focus solely on eligibility. When we scroll down a little bit further, you'll see that all of the eligibility tabs are laid out. And you can see that in this person's case, MA, which is here, is like a light gray kind of washed out, very hard to see. That's because they don't have any MA plan information. If they do have MA plan information, it would be like one of the blue, white, and blue boxes above. If you see a dark blue box, that just simply means that's where you're at today. But I'm going to scroll down and I'm going to find the MA section or the Medicare Advantage section. Oh, there it is right there. So it'll say, hey, they have Medicare Advantage MA plan, which is what the little MA stands for. And inside this tab, they'll have, the enrollment and retirement dates, the contract, and the plan. This is what I was talking about on This spreadsheet with the contract number and the plan type, that translates back here. So we're going to give you that. MA name, address, phone number, and website, if available. One of the things that happens with this right here is sometimes it's a legal name versus what you're going to know it as, and that's why you'll need to use this contract and plan number up above. And then the enrollment type and the billing options. So you'll be able to get all kinds of different pieces of information from this, and this is all what CMS provides back to us. It's not something that we control or have any information. It's done through that transaction. I'm going to ask Karen if she has any other input on this particular resource.
No, Tom, I think you did a really great job of covering that. It is an option, and it'll let you know exactly where you need to go with that bill.
Okay. Thank you, Karen. Again, the reason that I asked Karen is she does the SecureNet stuff, not me, so I don't really do a lot with it other than to know that it's there. Okay, so if you've checked eligibility and it's wrong, what do you do? Well, here's where you have to stop. If you bill us and it says there's an MA plan on file, we're not going to be able to pay that claim. If you bill us and there is no MA plan on file, but there should be, we're going to pay the claim. But as soon as that file is updated, what's going to happen? You're going to get an unsolicited response to the common working file, which is then going to send something to us saying, hey, take that money back. So you want to make sure everything is current and accurate before you bill it. Let's see. Is there a place in the WPS site where the patient's MA contract number is listed? Again, MA contract, right? Somebody asked us, I think this is kind of an interesting question. What happens when it's not listed, or why is all of this information not there? Our basic answer is if CMS doesn't give it to us, we can't display it for you. So incomplete fields in that transaction, that 270, 271 transaction, will cause incomplete fields in our system. It's something that CMS isn't offering to us, so we just simply don't have it to display it. A couple of other things to be aware of when we talk about MA plans and really about these types of denials. First, I was asked, how do I explain this to a patient? That's what this top one is. This is Understanding Medicare Advantage Plans. It's a booklet. You can either use the link, or to give you an idea, if you go to medicare.gov and you go, well, I guess I don't need to keep that open, but you can go to publications to find this, forms, publications, and mailings, and you can see it's under resources, under basics. And this is where you'll find a variety of publications. But what's great about this is the way that it's written. And the reason that it is written that way, you can see right here, Understanding Medicare Advantage Plans, open the PDF, is that it's written in a manner that is much easier for the patients to understand versus some of the stuff they write for us and the provider community, because it is more complex and we are written at a higher grade level. So I like this if you're just trying to get through it. This is another reason I like it, is these charts that are within it that'll help you understand any of those, like the special needs or whatever. And sometimes the patient's going to ask you guys questions and you're like, I don't know. Get more information. Refer to 1-800-Medicare. You don't know it, don't try to help them with it. Let 1-800-Medicare do that job. Okay. So it's a little bit about the patient plans, which again is understanding this booklet. I do think it's an important piece of information. On the other hand, there are websites on the CMS website. This is just another one. Sorry. This is cms.gov Medicare Advantage Plans. This one is important, especially if you're doing opioid treatment programs. Because of the type and the focus on this, they have a separate page for it. So I wanted to point this out. I did receive a question on that, and they were struggling to get opioid treatment programs paid for Medicare Advantage plans. I don't know what your struggle is or was, but this is what you're going to look for. So under payment, opioid treatment, and Medicare Advantage. This is just health plans in general. Again, it's just some information in general. Medicare Advantage resources, again, it's cms.gov. Sometimes the plans themselves will need resources, or the providers will need resources. So this just gives a bunch of different information. These are not resources that I look at or that Karen would look at, because they aren't aimed at us at all. We don't deal with any of this. So I don't have a whole lot of information on what's in there. I just know there are some additional CMS resources. All right. That brings us to the next section, and I want to remind everyone that our answers are going to come from the fee-for-service area. What I am going to do is try to get through all the pre-submitted questions. Should I then have time, I will go back and open it up for questions submitted in the chat, okay? So, oops, nope. Pre-submitted question number 1. What information, if any, from Medicare are we allowed to send Advantage plans for denials? The answer is you can send anything that is available, right? An MA plan is the same as Medicare. One of the pieces we would encourage you to send is an NCD or an LCD, should that be the coverage guideline that's causing this. Also, I'm not sure what's causing the denial or what the service is and why it's being denied. So that may drive what you need to send, but you can send anything to them. If you continue to have problems after you've given them that information, you may need to go to the regional office with control over that plan and provide them the same information and explain what the issue is. What they do from there, we don't really know what's going to happen, so I don't have a whole lot to offer. This next question starts off with, we bill on a 1500, which is true for traditional Medicare. However, some of the MA plans say you have to bill on a UB04. Should they follow the same guidelines? Okay, this is very interesting to me because this is one of those examples where as long as they're paying the same benefits, as long as they're covering it in some way, then they could require you to bill on a UB04. They could do whatever they want to do for that. Where traditional fee for service may say bill in a 1500. It's not that they're not covering it, they're just requiring the billing to be different. So that's not necessarily wrong to do that. One of the biggest questions that we got was about either an individual denial from an MA plan or what happens, how does it work for MA plan denials? So each MA plan has an appeal process. The thing that can be different is their appeals process. What do they require you to do? They are required to offer an appeals process. When you're looking at that appeals process, though, they're going to follow their own rules and their own information that they have available. So we can't talk a lot about that, but you do have to follow their appeals process. With that said, I was asked very specifically in Medicare, if you kind of go down, you'll see appeals and grievances. And then under appeals and grievances, you'll see Medicare appeals or managed care. Sorry, not Medicare, managed care appeals and grievances. And inside there, CMS does provide you with some basic information, update Part C plans, all of this types of information. Please take time to read through this. We are not involved in this type of a process. This is for the Medicare Advantage plan, which is why I'm giving you this website. Okay. Also be aware Karen's going to stick that into the chat for you. The next question makes, again, you just heard me go, It does make me go, And it's, why is there so much variation between traditional Medicare rules and various MA plan rules? The variation is allowed and it is encouraged for patient coverage choices. Remember, the whole point of a Medicare Advantage plan was to give the patient a choice in how they want their Medicare coverage, the benefits that they want, the administration, all of that types of thing. So that's where it comes from, and that is really the goal of it, is to allow those choices. Okay. So a lot of people did also ask about prior authorizations. Look, fee-for-service Medicare, very limited prior authorizations. Hospital outpatient departments, a few there. Um, Repetitive scheduled ambulance transports or RASNet, one there. Other than that, though, prior authorizations for MA plans can be based on the type of plan. And remember, we talked about that, especially with like an HMO style. You're going outside your provider network or you're actually going outside your primary care, they can require prior authorizations for any of that. So it's a very different process. And so if you're getting a lot of them denied, there's not much we can do or say. You would need to contact a plan and figure out why they're denying them. Because traditional fee for services uses prior authorizations very sparingly and limited and in limited circumstances for limited services. Should you follow the Medicare guidelines or the Medicare Advantage Plan guidelines? Interesting question, because when a patient elects Part C and you are a provider that has agreed to Part C, you are going to follow their guidelines for their patients. However, that doesn't mean you don't follow traditional fee-for-service guidelines. You would if that patient did not elect a Part C plan. So you may be stuck trying to follow the same basic benefit package, but different guidelines to get those benefits paid. So I don't have a really solid answer other than that. Um, Someone asked me what the best phone number is to check for denials. This is a really hard one because each Medicare Advantage plan has to have its own customer service line. We have one. Ours for this program would be based in calling and saying, I don't understand why I'm getting this denial, or the system doesn't show a Medicare Advantage plan, but you're telling me, hey, there is one. That does happen, and it means that the system was updated. So we denied it. We're sending you a message saying, hey, this is returned to provider, this is unprocessable, this is whatever, except there's nothing in the system to show that now. That means something was updated. On the other hand, if it truly is an MA denial, you need to check with each plan, and they need to tell you what's going on with their denials, their systems, their audits, and their edits. Okay. Um, so there was a couple of questions about lifetime psychiatric days and whether or not these are followed for MA plans. They have to offer the same basic benefit. However, one of the additional things they can offer is additional days, because remember, there's a limit. So while they do have to follow that fact that they have to give at least the same limit, it could be more. They could have to say you got to have the following authorization in place to use these lifetime psychiatric days, or a variety of other factors. It's just the same basic benefit. Um, how to deal with the differences of Medicare Advantage plans. This is one that will forever be a struggle for many providers and many provider representatives. The basic gist of it is we can only advise you on traditional fee-for-service Medicare, the data that we're seeing, which is what we gave you. If you need to deal with the individual plans and you don't feel like they're responding, they're not being responsive, they're not helping you get what you need, then you do need to go to the regional office with control over that plan. One of the big ones that I got was how do you get them to follow the rules? I'm going to assume you mean the fee-for-service rules or the regulatory rules coming from Medicare. And the answer is really start off with determining whether or not they are. Because remember, while they only have to offer the same benefit package, they don't have to pay them in the same way for the same amount. They could incorporate it into another service. So it's a variety of different factors in that. Um, just reading through the next couple of questions. Claims denied for primary invalid diagnosis codes. How do we avoid so many denials when there is a limited notes or narrative sending from the facility? Um, I don't know how to get you to avoid that, because again, the Medicare Advantage plan, they're the ones that have to tell you what they need. Now for traditional fee for service, sometimes there's certain like characters that we look for in there. Sometimes there's condition codes, occurrence codes, and span codes, depending on the type of claim. Sometimes we tell you it has to say this exactly in this field. So those are ways to be aware of it. But with MA plans, it's really not something we can help you with, nor could like just general system questions be answered, because each system is different and unique. With that said, that did bring us to the end of the pre-submitted questions. We did get through all of those. Let's see what we have in the chat. Karen, anything?
Hey, Tom, we have had a couple of questions come through the chat. I'm going to start up at the beginning. When you were talking about like the physicals, things like that, we were asked if the level of service is not agreed with, would it result in a partial or a complete denial?
From the MA plan, we don't know. And so if they say, hey, we don't agree with your level of service, they can deny entirely, basically saying rebill it at a different level. They they could do a variety of different things, from traditional fee for service. If that level of service isn't agreed to, and we're talking about some of those basic things, it would probably be more of a routine denial for a routine service. So that one's really hard to answer because I'm not really sure which way you want me to go with it. Next question.
Okay, the next question is, I thought that the Code of Federal Regulations states that Advantage plans need to cover Medicare services if a provider participates with Medicare and doesn't participate with a particular MA network. My question is, can the MA require a provider to sign a waiver, or can we submit the claims and expect payment without jumping through the hoops and signing agreements that the MA plan requests? Just trying to clarify that we should not have to sign an agreement of any kind with an MA plan if we don't participate with them in order to utilize the Medicare benefits.
That's an interesting question because it does state that, and no one's going to deny that. Here's the other thing they can do, just like with traditional fee-for-service Medicare, they can require you to enroll. Or they can come back to traditional fee-for-service Medicare and look at our enrollment system to verify that you are what you are, you have what they need. So it's not quite as cut and dry as that sounds. Like, I know what you read and it sounds very cut and dry, right? It is not that cut and dry. And that is because they can still require certain portions of enrollment. They can still require certain things to say, hey, we offer this additional benefit. If you want that, hey, guess what you have to do, which is additional enrollment, because we have to verify that you're even eligible to perform that service, where traditional fee-for-service Medicare wouldn't do that. So when you say jump through hoops and sign contracts, it's a lot like if you're a physician working with Medicare and you say, hey, I'm not going to do the participation agreement. On the other hand, I'm going to decide on a claim by claim basis. Yet you still have to do the basic enrollment. That is two different types of things. I know it's not exactly the same. It's just my example there. I just looked at the time and realized that we are out of time. So any other questions that are in chat, we will go ahead and email those back out to you. If they haven't already been answered somewhere else. I apologize for running out of time here, but let's get this done and on with. You will receive an email. Now the system is going to generate this, and it's so long as you have given us your email address when you registered. For those that just called in, you will not get this email. Want to make sure that you're aware of a couple things within the email. One, I will ask you to take this survey again and again and again, but the email is going to do the same thing. Second, there is an area called a certificate, and a certificate of achievement has contact hours. We don't offer CEUs, but we do offer contact hours, which can be translated to CEUs, but your governing body has to decide that. If you have follow-up questions, we're going to take them for 7 days, and our goal is then to take all the questions from the chat that we didn't answer and the follow-up questions, throw them into an email, and send those out to you. So if you have those, please make sure you email us. The email is here on the slide. It's also going to be in the chat from Karen. It's also on our website. If you go to the training center, you'll see it all over. So just go ahead and do that for me. Want to remind everybody that, again, I've mentioned this a few different times. Take our survey. Tell me what I did well. Tell me what I didn't do well. Tell me what WPS as an overall does well. This survey is used by both CMS and WPS to determine a variety of things and factors, but really to grade this webinar. One thing I want to remind you is that the survey will ask you to incorporate feedback on topics you want to see in the future. Please do that. Otherwise, we're going to use whatever we have available to us from the data to give you a topic, and sometimes that's not really what you need. So we really do recommend and encouraging the survey, if for nothing else, just to give us some topics. Thanks for attending, everybody. I appreciate your time today. I hope you found this information valuable. Take this survey, provide that feedback. That's great information. On behalf of myself and Karen, you can thank you for attending, and you may now disconnect.